Okay, good morning, everybody. Nice to see everybody this morning after the barbecue last night. So welcome to session 4 on countermeasures and interventions. I'm Louise Cosby, Queen's University and the Agri-Food and Biosciences Institute. My co-chair this morning is Dr. Isabel Webb from the University of Bristol in the UK. So I'd like to have great pleasure in introducing our first speaker, Professor Teresa Lambe, or Tess, who is the Kaliva Head of Vaccine Immunology and a professor of Vaccinology and Immunology at the University of Oxford. She leads a research group which improves human health by controlling disease through vaccination. And she is one of the principal investigators who oversaw the Oxford's AstraZeneca vaccine program. She co-designed the vaccine in January 2020 and led the preclinical studies, and then oversaw the delivery of the immune results needed to support regulation approval in late 2020. So we're absolutely delighted to have Tess here this morning. So thanks very much.
First of all, thank you very much for inviting me here today. I see lots of friends in the audience, and thank you for the very warm welcome. I will preface this talk by saying there's no one person who could have delivered all the work I'm going to talk about. It was a global effort with a global team, but some of the opinions expressed in this presentation are definitely my own. As I have a captive audience, I would like to speak to you a little bit about vaccines. For me, vaccines are the most important medicinal intervention that we've ever come up with. This is a very simple, very old infographic from Public Health England, which is now Health Security Agency, that demonstrates the number of vaccine-preventable diseases that occurred before a vaccine was introduced and then after a vaccine was introduced. But what are the types of characteristics that, as an immunologist, vaccinologist, and vaccine manufacturer, that I become obsessed with when I'm trying to make a vaccine? Well, first and foremost, it's safety. There's no point in me designing a vaccine that's going to induce side effects that are worse than the disease we're trying to protect against, or are not tolerable so individuals do not see the complete course through. Obviously, we would want protection against severe disease, and we want that protection to be sustained or long-lived. So we need to induce an effective immune response, inducing both antibodies and T cells. And the things I didn't think about when I was bright-eyed and bushy-tailed were the practical considerations, but now I think about them day in, day out. And the first thing I think about is cost. There's absolutely no point in me designing a vaccine against a disease of impact in LMICs, low and middle income countries, if it can't get into the arms I'm trying to protect. So the other thing I think about is the stability of the vaccine. How long will this vaccine live? What is the shelf life? How will I get it to the people who need it? Does it need cold chain storage, or will a fridge do? And when it gets there, how am I going to deliver it? Is it going to be up the nose, under the skin, in the arm? Because again, all of these impact the cost of the vaccine that you're designing. And then I like to take a moment or two to segue into this cartoon from Edward Jenner. Edward Jenner is frequently referred to as the grandfather of vaccination. It's a little misleading. There had been many countries and many people and many physicians doing vaccination and variolation before Edward Jenner. Regardless, he and others noted that milkmaids who had come into contact with cowpox were then protected against smallpox. And smallpox was a devastating disease. It's thought to have claimed some 500 million lives. And it's only one of 2 diseases that have been successfully eradicated through vaccination. So Edward Jenner did some very crude clinical trials back in the late 1700s, 1800s, definitely wouldn't get through my ethics board today. But he essentially inoculated individuals with cowpox-derived material and then exposed them to smallpox and saw that they were protected. What was disheartening that even back at that time, there was cartoons appearing in the newspapers suggesting that you would develop bovine-like characteristics if you were to get vaccinated. To the best of my knowledge, nobody's turned into a cow from a vaccine, but this kind of anti-vax movement is nothing new. It was certainly seen with a ferocity during COVID, but I don't know that we've actually come up with better tools to deal with it. And I'll touch on that a little bit later when I talk about the level of communication that we as scientists, vaccine developers and immunologists, there's an onus on us to get out there and to help educate the public so that they can ask us difficult questions like, will I turn into a cow from a vaccine? So after the Ebola outbreak that started in 2013 in West Africa, and there was a number of government bodies and the WHO came together and put together a hit list, if you will, for those pathogens of concern, those pathogens that they thought might cause the next pandemic or epidemic. And I suspect you will know many of these viruses. You'll definitely have heard of Zika. Everybody has heard of SARS-CoV-2, disease X. But there are some there you may not have heard of, such as Crimean Congo hemorrhagic fever or Rift Valley fever. Regardless, there was an impetus to develop both vaccines and therapeutics against these pathogens of concern. And we at the University of Oxford and many, many other universities and industrial partners took up that mantle and started to make vaccines against these pathogens. So how do you make a vaccine? So I'm going to give you a bit of a crash course in that so you can all do it once we've finished this lecture. Well, first and foremost, you need to know what is the pathogen that is causing the outbreak. So you need good diagnostics and you need good surveillance. Once you've identified the pathogen of interest, you need to identify targets on that pathogen that you think, if you had a strong immune response against it, you would be protected against overt disease. And if you take SARS-CoV-2 as an exemplar, the spike protein is how that virus gets into our cells, how it mediates damage, how it makes you poorly. So really, if you can block that interaction, if you can induce neutralizing or binding antibodies to spike that inhibit SARS-CoV-2 entering the cells, you're going to get protection from overt disease. And with the broadest of brushstrokes, that's in essence what viral vectors and lipid nanoparticles do. They carry the genetic code, the recipe, if you will, for the spike protein into your body. Your body starts to make buckets of this small part of SARS-CoV-2. Your immune response sees it as something as alien and induces both antibodies and T cells against the spike protein, hopefully at a level that you will be protected against. Viral vectors and RNA technology are not new. They have been around for decades, and they've certainly been seen as the darlings of COVID-19. But I'd like to highlight that there are many other types of vaccines that keep people alive and well, millions of people daily. And what I would hate to see is because of a pivoting of investment towards what is seen as the newer techs, there is a lack of investment in these older techs. And in fact, we don't know what the next pandemic will be caused by. We can guess, but there's nobody who can tell you definitely what the next pandemic will be caused by. So we can't definitively say which technology will be best placed to protect us. So I would hate to see a disinvestment in whole virus and protein subunit and other vaccine technologies at the expense of continued investment in RNA or viral vector. Let's try fund them all. So one question I frequently get is, what do I do and why does it take me so long to make a vaccine? And what I'm hoping to do with this slide is answer that question. So vaccine design can take as little as a weekend. That's what myself and my colleague Sarah did over the weekend in early 2020. But normally in non-war times, it will take you months, especially if you've got a complicated pathogen. And then you want to start on your preclinical studies, and you really want to start small there. You want to vaccinate small animals and see if you're getting an immune response that you think will be protective. If you get that, you'll progress on to large animal studies. And really in those large animals, what you're ideally hoping to see is an immune response that will protect them against challenge. If that doesn't happen, you're back to the start again. So this is a very iterative process. You take one step forward to take two back, to get the best product by the end of the time you've designed and by the time you've tested your vaccine. We're relatively lucky in Oxford in that we have an on-site facility that will make GMP material, and that's material that is fit to go into a human. But that will cost the academics in and around £1.5 million. So as you can see, vaccine design over a weekend doesn't cost a lot. By the time you've got to this stage, you're investing a minimum of 1.5 million, and then you've got the trials to deliver. And as you progress along this timeline, each of these steps don't increase to a small degree. It's astronomical, both the time, effort, and money that gets invested. So again, you will frequently take a step back to have the best product going through to licensure. So it's not that we're lazy. It just really does take this long to generally get therapeutics or vaccines to market. And that was certainly the timeline that we were looking at when we started with our journey trying to make a vaccine against Middle Eastern respiratory syndrome, which is caused by the MERS coronavirus. It has a higher case fatality rate than SARS-CoV-2, but does not spread as readily. The zoonotic reservoir is camels, and it's frequently individuals that work with camels and have comorbidities that will succumb to this disease. So we did what we do. We looked at the MERS coronavirus, identified the spike protein as the antigen you would like to have an immune response against, put the coding sequence into our ChAdOx1 platform technology, and started with our small animal studies. So we started in mice, and then progressed to monkeys. And we were able to demonstrate vaccine efficacy in both a small preclinical model and in our monkey studies. In addition, we've also done some studies in camels to look at transmission. So a single dose of our vaccine was able to protect monkeys against the pneumonia caused by MERS-CoV. And that gives you the confidence, and it certainly gives funders the confidence to generate a GMP batch of the vaccine, which we did with our on-site facility, CBF, and we started our clinical trials in March 2018. 24 participants were enrolled, and a single dose of this vaccine induced both antibodies and T cells and was tolerated relatively well. You tend to get a sore arm and flu-like symptoms if you've had a viral vector vaccination. But when SARS-CoV-2 struck, we looked at the development process and timeline, and we realized that it would be too slow. Too many people would die. So what could we do to speed the process up? What risks could we take that would mean we could deliver this vaccine faster? First and foremost, no risks were on our volunteers. When you are doing a clinical trial, the thing that is first and only in your mind is the safety of those volunteers. So every step that would have been done in that 5 to 10 year program was done in a year. The risk that we took was a financial risk, and it wasn't my money. It was the UK government's, it was Serum Institute, and it was AstraZeneca. And the risk that they took was before we had readout even from our phase 1 clinical trial, they were already upscaling the GMP manufacture, and that's a huge amount of cash that has to be invested. And again, while we were running our preclinical studies, in fact, as you'll see in the next slides, even when we were starting to do our small animal studies, we were scaling up our GMP manufacture, and at that stage it was a risk, and it was a risk the university bore, the financial risk. So what are the lessons I've learned? You need to plan for the future, and you need to plan many steps ahead. Plan A isn't going to work, B, C, D. You might be lucky by the time you get to X, Y, or Z, something will have come off. So for example, during the COVID trial, there was one point where a private jet was chartered on a Sunday to get vaccine from Italy to the UK. That's not something that we would routinely do. I fundamentally believe that you need to partner with pharma early. Academics are great. I am an academic. We're great at blue skies thinking. We're great at pivoting. We're great at moving fast. We do not have the manpower, the woman power to get a vaccine all the way through licensure. So we need that partnership relatively early on, and you need to be aligned in what you're trying to do. You do need to work at risk, but always prioritize the safety of volunteers. And the reason that we were able to deliver this, and I use we in a global sense, this is all the vaccine manufacturers, is that there was an open and honest conversation going on with government regs and international bodies. So to bring you through some of that journey, this is the preclinical studies. To say we were a small team back then is not misleading. That's me in the hood making up the vaccine to go into mice for the first vaccination. One of the few times I've been allowed back into the lab because I am messy and my writing is illegible, but regardless, the mice were vaccinated. And then the impetus really kind of garnered, the need for speed really started to ramp up in February and March. And we reached out to our friends and colleagues globally to enable these vaccine studies in animals. And you have to realize that when you're setting up these challenge studies in monkeys, they generally take years to set up and deliver. But our colleagues were working again around the clock setting up these studies. So we did some work in monkeys, ferrets, pigs, hamsters. And the reason we did so much was at that stage, there was a concern around antibody-dependent enhancement. And that is a phenomenon that has been seen with some other vaccines, where in essence, individuals and or animals which are vaccinated with a vaccine actually have a poorer or worse outcome than those that are unvaccinated. So we did a lot of work trying to see if the responses that were associated with that type of immune deviation, particularly Th2 immune deviation, was seen with some candidate vaccines against SARS-CoV-1, were seen in the animals that we vaccinated. And we didn't see that. In fact, some of the studies that came in late April, just before we started vaccinating, demonstrated that we actually got complete protection in rhesus macaques. The vaccine was released to trial in April. We partnered with AZ soon thereafter, and we had very lovely volunteers come in and get their first vaccination. What was not so lovely was when those volunteers woke up to news stories 3 or 4 days later saying that they were dead. They weren't, but they had to make many rapid conversations with both their friends, family, and the media to try and counter that fake and false information. But once that genie is out of the bottle, it's really hard to get it back in. So people to this day still believe that our first volunteers died in the vaccine trial. The trial started in earnest in April, but while Andy Pollard is not someone who goes slow. So while we were delivering the phase 1 clinical trial, we also started the phase 2/3. And we started it within the UK, but at that time, the UK was doing what it should have been doing, which was, it was in a lockdown, people were not going out, they were not catching COVID. So in effect, we couldn't actually test our vaccine. We couldn't see if it was keeping people safe. So we reached out to Suwan in Brazil, Shabir in Africa, and Georgia Mayanga in Kenya. And through our collaborative effort, we were able to demonstrate that the vaccine was efficacious. This is the busiest slide you will see today. And it's because I still get questions about why we came out with 3 different numbers around vaccine efficacy. So if you listen to me a little bit, as opposed to look at all the numbers, hopefully I'll be able to walk you through it. The first thing that I would say, and I do this, I'm guilty of this, is it's not a great idea to compare across trials. The reason it's not a great idea is that trials will define disease differently. We were looking for any impact in mild, moderate, or severe disease, while other trials were looking for impact against moderate and severe disease. There's different demographics, there's different variants of concern, there's different regimes. So comparing efficacy across trials is difficult at the best of times. But really what was most confusing, and we still get questions about, is why did you have a 90% efficacy, a 60 and a 70? So within the UK, we had two vaccination regimes. We had individuals that got a half dose followed by a standard dose. And then we had individuals that got two standard doses. And what we saw was that in those individuals that got the half dose followed by the standard dose, there was a higher vaccine efficacy. Why? We didn't know at the time we released these results, because once you've done the data crunching, you have to come out with these results. But once we had a little bit of time to dig into the data, what we were able to demonstrate was that with the increasing intervals, so the increasing number of days between the first and the second shot, you got an increase in antibody titer. And it was that half dose followed by standard dose that had these longer intervals and higher antibody titers. Therefore, the first demonstration of a putative correlate of protection from the Oxford AZ vaccine, which was not surprising because everybody was banking on it being binding or neutralizing antibodies. So 2020 was a year of thirds for me. I thought I was busy at the very, I thought I was busy at the very beginning of the year, designing the vaccine and starting the preclinical trials with, again, a huge team delivering it. Ramped up significantly in the middle of that year, trying to get the immunology results for all the trials and the trial delivery. But it was really the latter part of that year that I would hate to go back to. And there's not much populated here to explain why it was so horrendous. But one of the reasons was the amount of pressure that was on the team to get those results out, making sure that every sample from every volunteer, from every visit, from 6 different sites within Brazil, 14 to 16 within the UK, were sent to the right labs for the right analysis, was a horrific logistical challenge. In multiple lockdowns, we couldn't get liquid nitrogen, we couldn't get anything to get all of these samples exported. But we did, and we got approval towards the end of 2020. And I remember thinking that 2021 was going to be a slower year and it would be okay. And on New Year's Eve, I was doing what most people in the UK were doing. I was doing a Zoom call or a Skype call with my family, having a glass of bubbly. Got a phone call from Andy Pollard saying, we have a problem back in the lab on New Year's Day. And again, that was a team of us. It wasn't just one or two of us. But really, what impacted the team most significantly, or actually I should say what impacted me most significantly, was the results from the wild, the real world data demonstrating that these vaccines were having an effect, that they were keeping the most elderly, the most frail, those individuals that would and could succumb to SARS-CoV-2 alive. And the other thing that impacted the team was the onus on us to get out there and to communicate our findings. I was and am a geeky scientist. I get excited about seeing results, and I think they should be able to speak for themselves, but they don't. And that's something we learned the hard way. If we're not out communicating that we're not doing this to put a microchip in your arm, that your unborn baby will be safe, in fact, safer with a vaccine, then it falls to miscommunication and disinformation. And there was coordinated attacks across a number of the vaccines around this misinformation that resulted in individuals not getting a vaccine and unfortunately succumbing to the disease. I've already alluded to the story around our first volunteers, but this was a news article that, a news report that came out during the COVID journey. And as you can see, there are very close similarities to what this presenter is presenting and that cartoon that I showed on the very first slide. And it's disheartening, and it was certainly very demoralizing for the staff. But equally, this is why I put brownies here. I'm not obsessed with them. We got loads of support from our community and our friends. And on one instance, I didn't see, as with many of the team, didn't see most of our family through 2020. To curry favor, I bought them a delivery of brownies at ridiculous expense so that they'd remember who mom was. Came in the next week, and the vaccine team had had an even bigger delivery of exactly the same brownies. So it just goes to show these small gestures, the letters of thanks, really did mean a lot to the team that were delivering this. What are we most proud of? And I think I can use we here as speaking for the global team and AstraZeneca. And AstraZeneca have done a fabulous job at getting approvals and emergency authorizations in over 100 countries to date. More than 3 billion doses were released to supply. Approximately 2/3 of those doses went to low and lower middle income countries. That's something that I'm really proud of. And it's estimated that this vaccine alone has saved over 6 million lives in 2021. What I'm less proud of that we delivered as a global community is getting those vaccines into the arms of people who needed it in low and lower middle income countries. This is the vaccine rollout and where it went from December 2020 to June 2022. And you can see that there's a huge lag. It shouldn't have happened like that, and it definitely should not happen again. So what do I think are the critical success factors for a proactive approach towards pandemic preparedness? Not surprisingly, first and foremost, we need to invest in people and places. I don't want to do that again. I suspect nobody in the team really wants to do it again, so it's got to be you guys in the audience who do it next time. And without that investment and established alignment of global collaborators all pulling in the same direction, we're not going to be able to do it again. We need to have an open, ongoing dialogue across government, regs, industry, and academia. The funding model, certainly within the UK, has been broken. There does seem to be an impetus to try and improve that, but I'm not sure that it's quite got there just yet. I believe that in an outbreak, you need rapid access or alternative funding approaches, writing a grant, waiting 6 months for a review, and then waiting another 3 months before you get the money. There's too many people who succumb to the disease. You need long-term investment in these programs, but you also need in-country investment. So what do I mean by that? I mean investment in the countries where these pandemic viruses are going to come from. You need that to be sustainable, joined up, and in that way, I think you'll be able to build a strong science and medical research base, have some fun generating scientific results along the way, and hopefully generate impactful clinical research and health outcomes. So it just remains for me to acknowledge the huge number of people that were involved in this. And one last comment, there's going to be a number of open positions in my lab. So if you're interested, please do contact me or drop me an email with a CV after this talk. I'm very open for any questions you might have. Thank you for listening.
Thank you so much, Tess, for a very insightful and wonderful talk on your vaccine journey. Have we any questions from the audience? Miles?
Thanks, Tess. Lovely overview. And I'm really glad that you talked about the issues around vaccine-associated enhanced disease, which did control the progression to, well, to phase 2, though some phase 1s were done before that data was available. And also, you know, how, in my opinion, how brilliant AZ were, and that they didn't go for profit. They kept the cost down. But can you explain, or I know it was put out to me, why so the FDA didn't license the AZ vaccine, but it licensed the 2 RNA vaccines?
Certainly. So if you remember the landscape back then, it was quite interesting, both scientifically and politically. And at the time that the AZ were going for BLA, it was felt within the US that the market was saturated and it was no longer needed. And I'll leave it there. Maybe over a glass of wine, I can tell you all the rest of it.
Yeah, I was going to ask you, I know you had a horrendous journey with the social media and press and so forth. I mean, is there any advice you'd give or any kind of further actions you think can be taken to get around that in the future?
Yeah, it's a good question. I really liked the session yesterday around the social scientists and the need to kind of interact with that sphere of engagement as well. It was horrendous. Members of the team received death threats. You would wake up to the most awful emails in your inbox accusing you. And we had protesters outside of where we worked. I don't know that there's any magic wand that is going to fix any of this. There was a naivety, certainly I was naive, around how organized some of the communications and how targeted that was. And I think there's an onus on myself and others who have gone through this journey, including, so there will be lessons learned from Ebola as well, to pass that on. To have an institutional knowledge so that when the next time there is a pandemic, and there will be, that we deal with that upfront. But it is organized, it's well funded, and it's targeted, and we don't take it seriously enough, in my opinion.
Any other questions? No? Okay, well, I think we'll move on. Thank you so much. Yes, one up the top, sorry.
Yes, you.
Yes,
I
please.
Hi, Teresa.
Hey.
We've all lived through this nightmare and we've come out relatively well. I think that the pivotal role of the NHP and animal models at the very beginning was really critical. But can you speculate as to what it would have been like if we'd have been facing a disease X which did not have an adequate or even possible animal model?
So I could just say harder, but that's a little a little unfair. I think you'd pivot to a disease model that was of a closely related virus. That's what I would have done. Trying to, you know the story, trying to get that animal model set up in the Rocky Mountain labs and many other labs was tough. And not all viruses will infect NHPs or green monkeys or et cetera, to the same extent. I think the best you could do is look for a platform that there's a lot of safety data around and look to a closely related virus and see if you are seeing ADE. But certainly if you'd done that with SARS-CoV-2, you would have looked at SARS-CoV-1. And in certain vaccines, generally whole inactivated, but not just whole inactivated, and certain animal models, you were seeing this ADE. So I think it would have been difficult if we hadn't have had those animal models. We were lucky, and I don't think we feel lucky, but we were lucky that we were able to do this. We were able to make a vaccine. There's so many viruses we can't make a vaccine against. And we were lucky that kids weren't impacted, because generally with respiratory pathogens, it's kids and older adults that are most impacted. So while it doesn't feel, and we shouldn't feel lucky in general, considering the number of people who succumbed, I don't know that we're doing the most that we can for the next virus that might be worse. Sorry, that was quite a depressing note to end on. So if anybody has a nice question.
Okay, any further questions? One up there. Right, yeah.
I don't know if it's a nice question, so I'll I'll do mine first, and then you can do your nice one at the end. In other emergency areas, there's regular training. You know, we practice disasters with trains with lots of volunteers. With the army, there's regular practice to test things. And particularly, I think, bearing in mind the effect it had, the ability to practice psychological well-being during an emergency, and in the absence of being able to scale up regularly because of the cost. What do you think is the most important thing we can learn to look after our teams and ourselves for the next time we find ourselves in such an emergency?
So we didn't do that well. We didn't look after the well-being of the individuals who delivered this. We treated it like a sprint. And it has and remains a marathon. I'm still doing work on COVID vaccines in the 3rd, 4th, 5th doses. And what you've seen is fatigue, and you've seen the most skilled individuals start to drop out. And we're losing that knowledge in many, many different parts across the UK, and I suspect globally as well. you need to recognize in your staff that there will be a fatigue, that we do need to have extra resource and cover, that they need breaks. And I don't mean a break of a weekend off. I mean a couple of months break of delivering this type of high intensity, huge responsibility. And these individuals take it on their shoulders. They bear it, and then they can come out broken. So you need to look after your team really, really well. I would say that I would like to see the types of learning from those teams essentially embedded in the army, embedded in government, embedded in our universities. I don't know that I have seen that to date, but it's certainly something that we're trying to do as an academic institution.
Okay. Thanks very much. One more at the top.
Thank you for an excellent talk. There are several coronaviruses, such as feline infectious peritonitis, where vaccination with recombinant stabilized spike ectodomains cause vaccine-enhanced disease. What steps did you take early on to ensure that your vaccine wasn't causing enhancement of disease?
So we did. So in some of those studies, you'll see a predominance towards or a shift towards a Th2 type response. So we vaccinated ferrets, pigs, mice, guinea pigs came later, NHPs, and looked at the division between the IL-2, IL-4, 5, 10 axes to see if we were seeing that kind of shift away from what we thought would be a protective Th1 response to a non-protective deleterious Th2. We also did vaccine studies looking at protection in ferrets and in NHPs. And in fact, the study that we did with Rocky Mountain Labs, the NHPs, we had a Chadox1 GFP, so a control group, a 1-shot and a 2-shot. And we did a lot of pathology to investigate if we saw infiltrates in the lung and elsewhere. So yeah, there was a lot of work done on that. And as Simon has already, we were very lucky we had those animal models set up so that we could look at those.
Okay, thank you. In the interest of time, I think we'll move on, but obviously people can catch up with Tess at the break. Sure, there's more questions. Thank you. Thank you again.